So, a 59-year-old female widow hailing from Kamalanagar, Bangalore, who is a homemaker belonging to upper middle class according to modified Kuppaswamy classification, came with the chief complaints of one episode of bleeding PV 1 week back and complaints of low backache and lower abdominal pain since 3 months. History of presenting illness: patient was apparently normal 3 months back when she developed lower abdominal pain and low back pain, which was insidious in onset and gradually progressive, diffuse in nature, non radiating, without any aggressive and relieving factors. She also complains of one episode of bleeding PV, which is serosanguinous in nature, minimal in discharge, non foul smelling, without any passage of clots, no prior episodes similar to this, without any history of fever, no itching, no history of bowel and bladder disturbances, no complaints of hematuria, no rectal bleed, no complaints of flank pain, cough, fever, dyspnea, no complaints of weight loss. Uh, Coming to past history, she has no known comorbidities like diabetes mellitus, hypertension, TB, or asthma. No history of prior hospitalization or surgeries. Coming to obstetric and menstrual history, she attained her menarche at the age of 11 years, attained menopause 8 years ago. Her age at first childbirth is 20 years, obstetric score being P para 2 living 2. Previous menstrual cycles were regular with 5 to 7 days flow without any history of passage or clots. Her cycles were 28 to 30 days cycles without any history of dysmenorrhea. Coming to personal history, her diet is a vegetarian diet, undisturbed sleep, normal appetite, bowel and bladder functions. Habits are regular, no addictive habits. Coming to general physical examination, patient is conscious, cooperative, oriented to time, place, and person. Her weight is 53. Her pulse rate is 82 beats per minute. BP is 130 80 mmHg. SpO2 is 97 percentage at room air. Her weight is 53.3. Height is 158 centimeters and BSA is 1.5 meter square. BMI is 23.6. There is no pallor, no icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There is no spinal tenderness or supraclavicular lymph nodes present. On local examination, consent was taken and she was examined in a well lit room in a lithotomy position. On inspection, external genitalia is normal. There is no visible discharge per vaginum. On per speculum examination, a proliferative growth was arising from cervix, approximately 5 into 5 centimeters. No bleeding, vaginal walls appear free. On per vaginal examination, per speculum findings were confirmed. It does not bleed on touch. Right and anterior fornix were involved. Posterior and left fornix were free. Vaginal walls were free from the disease. On per rectal examination, right parametrium was involved close to cervix. Left parametrium was free. Rectovaginal septum and rectal mucosa were normal. There was no adnexal mass felt on bimanual palpation. Coming to systemic examination, cardiovascular system, both the heart sounds were heard, no murmurs were heard. Respiratory examination, bilateral air entry was equal. Per abdominal examination, it was soft and no organomegaly. No palpable inguinal lymph nodes as well. Coming to CNS examination, no focal neurological deficits. My provisional diagnosis at this point would be carcinoma cervix 2B. I would like to go ahead with the routine blood investigations like complete blood count, liver function test, renal function test, serum electrolytes, coagulation profile, and serology. I would also like to do a punch biopsy from the edge of the cervical lesion, and I would also like to do a CT scan of abdomen and pelvis and chest X-ray, a PA view. My plan would be definitive chemoradiation with cisplatin based chemotherapy as per the NCI alert. I would like to go ahead with the radiation using 3D CRT technique. The patient will be immobilized using thermoplastic cast in supine position, arms above the head, and the CT simulation will be done with IV contrast with vaginal fiducial kept at the introitus. 5 mm cuts images will be CT simulation images will be taken from T12 to mid thigh level. We will delineate the target volumes, the gross cervical disease as the GTV, and the CTV target volume will be the cervical lesion plus entire uterus plus bilateral parametrium and upper 2 to 3 centimeters of the vagina. Planning target volume would be 7 margin to the CTV. The dose that is prescribed will be 45 gray in 25 fractions, 5 fractions per week with concurrent cisplatin for about 40 mg per meter square weekly. During the course of treatment, we will assess for acute toxicities and manage those as well. Following this, brachytherapy will be planned, that is intracavitary brachytherapy. First she will be assessed and then planned for intracavitary brachytherapy after 2 weeks. The procedure will be under spinal anesthesia, lithotomy position, parts will be painted and draped, an examination under anesthesia will be done, urinary catheterization will be done, os will be sounded, and flange will be fixed to the central tandem. Central tandem will be inserted into the central uterine cavity. Both the ovoids in the bilateral vaginal fornix applicator will be fixed, abdominal tie will be done, and rectal catheter will be placed. CT simulation scan will be undergone, and the patient will undergo CT simulation with bladder and rectal contrast with 5 slice thicknesses from again T12 to mid-thigh levels. RT planning will be done, and the dose will be prescribed to HRCTV. HRCTV is contoured, and 2 centimeter to that will be the IRCTV. The dose that will be given will be 7.5 gray in 3 fractions. Normal dose constraints to the rectum 2 cc to receive less than 65 to 75 gray, and bladder to 2 cc to receive less than 80 to 90 gray. Sigmoid colon to receive 2 cc to receive less than 70 to 75 gray. Following this, after this, the follow-up for the first follow-up will be after 2 weeks.